Neurology, Pathology, Brown-Sequard syndrome, Friedreich's ataxia, and Cerebral palsy. All right, very easy. First off, Brown-Sequard syndrome. This is a hemisection of the spinal cord. What it's going to present as in your question stem is someone getting stabbed in the back, all right? So they'll have a stab wound to the back, and that's going to be the primary presentation. Now, this is how you know it. You have loss of all sensation at the site of the lesion, okay? Now, distal to the site of the lesion, ipsilaterally, on the same side as the site of the lesion, you're going to have impaired proprioception and vibration, as well as fine touch loss, okay? Contralateral and distal to the side of the lesion, so on the other side of the lesion, distal, it's going to be impaired pain and temperature, as well as crude touch loss, okay? Makes sense, because pain and temperature need to cross over to be kind of sensed by the brain. So that's why it's going to be contralateral to the side of the lesion. Very, very straightforward. Honestly, majority of the time, Brown-Sequard syndrome is going to be a stab in the back, okay? So keep that in the back of your mind. Very easy. Next is Friedrich's ataxia. Friedrich's ataxia is an autosomal recessive trinucleotide repeat of GAA, okay? GAA. It's going to be on chromosome 9, and it encodes the protein frataxin, okay? Frataxin. Friedrich's ataxia kind of sounds like frataxin, so it's pretty simple there. Now, you have impairment in mitochondrial functioning. All right, so there's going to be degeneration of these following tracts, which are important. You have to remember these tracts that are degenerated. The lateral corticospinal tract, which causes spastic paralysis. The spinocerebellar tract, which causes the ataxia. The dorsal columns and dorsal root ganglia, which leads to decreased vibratory senses and loss of proprioception, as well as loss of DTRs, okay, deep tendon reflexes. All right, so remember those specific tracts that I just listed. Those 4 tracts are key. Now, what you can also get very easily is the symptoms, okay? So they're going to probably provide you with majority of the symptoms, and they're going to ask you which tracts are affected in this disease, okay? So remember those tracts. Now, the symptoms are these, okay? You're going to have an abnormal gait, okay? The patient struggles to walk. They frequently fall. They have nystagmus. They have abnormal feet, they have pes cavus, which is the high arches of the foot, high foot arches. They can have hammer toes. They will get diabetes. They will get hypertrophic cardiomyopathy. They'll get kyphoscoliosis, which is the abnormal turning of the spine. Okay, all of this is very, very high yield. They will present this with multiple different symptoms, and you're going to have to be able to pick out that it's Friedreich's ataxia. Now, the number one thing to take away that they're going to love to ask about is that the number one cause of death in these patients is going to be hypertrophic cardiomyopathy. All right, you have to know that. All right, so if you see a patient that has ataxia, loss of sensation of position, loss of proprioception, they have kyphoscoliosis, right? So they have the curvature of their back. They have HOCM, hypertrophic cardiomyopathy with diabetes and pes cavus, some type of abnormal foot, then you know that they're talking about Friedrich's ataxia. They will ask about, autosomal recessive GAA repeats. They'll ask about the frataxin protein on chromosome 9. They'll ask about the certain tracts that are degenerated, or they'll ask about the symptoms, okay? Very high yield topic, and it's very easy to understand. Now, the one thing, once again, that you can get this confused with is Charcot-Marie tooth. Charcot-Marie tooth is a lot less high yield, first off. Second off, you're only going to see foot abnormalities with weakness in walking with Charcot-Marie tooth. You're not going to see the other symptoms of like diabetes or HOCM, right? Or loss of sensation or the spinal cord issues, right? That is reserved for Friedrich's ataxia, okay? And lastly is cerebral palsy. Now, cerebral palsy, I'm going to narrow it down to 4 key things you have to know. 1, you have delayed motor milestones. So it's going to be, and once again, a very young patient, right? Because they're going to be born with it. It's permanent motor dysfunction. That's non-progressive. So they're born with it, and it's not going to progress into something like worse. It's just they're born with it, and that's it. So it's non-progressive. So 1, you have delayed motor milestones. Right? They're not going to be able to progress as normal kids are to progress when it comes to motor milestones. 2, you'll see spasticity. All right. So spasticity in patients that are young, all right, very, very young, like infants. All right. 3, you're going to see hyperreflexia. And lastly, you're going to see periventricular leukomalacia, which is just white matter necrosis. Okay. I want you to understand that the periventricular leukomalacia, which is just, white matter necrosis, that's honestly something that they'll ask about. They'll present the patient with cerebral palsy, with the delayed motor milestones, the spasticity, the hyperreflexia, and they'll ask, what will you see on imaging? And it's going to be periventricular leukomalacia, which is just white matter necrosis. All right. And the highest yield risk factors are prematurity and low birth weight. Okay. So that's all for Brown-Sequard, Friedreich's ataxia, and cerebral palsy. We're pretty much almost done with the neurological pathologies, and we'll talk about the ears and the eyes next.